Chapter 26, Penicillins and Cephalosporins. Bacteria. They are present in every facet of our lives, and they come in many different forms. Everything from bacilli, the elongated or rod-shaped, to cocci, the spherical. Other terms you may be heard of are staphylococci, which appear in clusters, or streptococci, which are arranged in chains. They can also take the form of either gram-positive or gram-negative. To combat these, we have antibacterials. These inhibit bacterial growth or kill bacteria and other microorganisms. Not to be confused with antibiotics. These are chemicals produced by one kind of microorganism to inhibit the bacterial growth or kill bacteria. We use these in things like bacteriostatic drugs that either inhibit the growth of bacteria or bactericidal drugs to kill bacteria. Antibacterial action either deals with the inhibition of cell wall synthesis, alters their membrane permeability, inhibits the protein synthesis, inhibits the synthesis of bacterial RNA and DNA, or interferes with the metabolism within the cell itself. Your body has its own innate defenses that it uses to fight against invasive bacteria. Everything from factors ranging from age, nutrition, immunoglobulins, circulation, white blood cells, and organ function. Unfortunately, antibacterials aren't the ultimate defense in that many bacteria, everything from MRSA you may have heard of, methicillin resistant Staphylococcus aureus, to potential dangers of the future like tuberculosis, growing more and more resistant to these antibacterials. And as we discover and pro- progress with antibiotics, these pathogens are also evolving and growing much stronger themselves and are able to resist each new advance that we make. And so that we're kind of in an arms race with these bacteria. Much of this arms race or this growing immunity to antibiotics and antibacterials is that the overuse and the misuse. We're using antibiotics in situations we really shouldn't be, giving them for viral infections when an antibiotic is not going to be effective in any way for a virus. Taken when no bacterial infections present, taking antibiotics incorrectly, such as skipping doses, or patients not taking the entire dose. There's a reason that the patient is told to take the entire prescription, and that if they only take it until the symptoms stop, there is still some of that bacteria remaining in the body. And what is remaining in the body is the part of the pathogens that are the most resistant to the antibiotic they've been taken. And that resistant bacteria now has free range to grow and proliferate again. Other theories are things like antibacterial soap. Or is it normal that we're killing off the 99.9% of bacteria on our hands every time we wash our hands, when that 0.1% remaining is now extremely strong and resistant to our antibacterials? Many times, these antibiotics will be taken in conjunction with other substances to potentiate the effect or increase their effectiveness, or an additive is added to double their effect to potentiate that effect. Or in the case of drugs like tuberculosis, the patient may be prescribed multiple very strong antibiotics, such as isoniazid in combination with rifampin. So if we're sure that we have wiped out that pathogen and we're not creating a more drug drug resistant variant within the body. Antibiotics can also have many adverse reactions. First is going to be an allergic reaction, and that many patients can be sensitive and have an extreme allergic reaction to these antibiotics. And often, especially in the case of penicillin, which patients are often can be commonly allergic to, when they're allergic to one psyllin drug, they could possibly be allergic to another psyllin drug. You also run the risk of superinfections or secondary infections. And these result when the antibiotics we've given the patient kill off the normal biota and flora within the body. You hear a lot about C. diff, Clostridium difficile, on the nursing floor. And in many cases, this is something we've done to the patient. This is something the patient's acquired from the antibiotics. And that antibiotic, while killing off the targeted infection we were going for, it's also killed off the normal healthy biota by bacteria within the patient's GI tract. And when that was killed off, it left free range for C. diff, Clostridium difficile, to grow and proliferate. Many antibiotics can also be toxic to certain organs, such as ototoxicity or toxic to the ears, liver, kidneys. You'll also hear a lot about narrow spectrum and broad spectrum antibiotics. A narrow spectrum antibiotic is one that's primarily effective against one specific bacteria type, such as penicillin, erythromycin. You may also hear about broad spectrum antibiotics. These are effective against gram positive and gram negative. They're effective against a wide range of bacteria, such as tetracycline or cephalosporin. And these are frequently used when the offending microorganism has not been identified by culture. Penicillin. This was the first antibiotic, invented by Alexander Fleming in 1928, and it works to inhibit bacterial cell wall synthesis. Types would include things like basic penicillins to broad spectrum penicillins, or extended spectrum penicillins, even. Or there could be the basic penicillins, narrow spectrum. These are effective against gram positive and a few gram negative bacteria, used for things like treating anthrax, diphtheria, endocarditis, pericarditis, skin and respiratory infections, or even scarlet fever, meningitis, gingivitis, or otitis media. On the other hand, broad spectrum penicillins, these are effective against both gram positive and gram negative bacteria. There were They work for a wide variety. And again, these are primarily used when we don't know exactly which bacterial infection the patient has. That's why it's so important we get those cultures before we begin a bacteria. It's in the lab. They can use that culture to both positively identify that bacteria and also see exactly which type of penicillin it would be most reactive to, which penicillin would be most effective. Penicillinase resistant penicillins. These are narrow spectrum and they're effective against gram positive bacteria. Things like Staphylococcus aureus, treating things like endocarditis, meningitis, and also skin and respiratory infections. And extended spectrum penicillins. These are effective against those gram negative bacteria. Pseudomonas, and treating everything from respiratory, intra-abdominal, urinary tract, and skin infections. Beta lactamase inhibitors. They inhibit bacterial beta lactamase, extending their antimicrobial spectrum. They are not given alone and are often combined with a penicillinase sensitive penicillin. Unfortunately, penicillin can have many side effects, as we discussed, that hypersensitivity, those allergic reactions, potentially even up to anaphylaxis. It can also result in superinfections, tongue discoloration, GI distress, arthralgia, and that Clostridium difficile, that C. diff. When giving penicillins, we want to assess for any allergy to either penicillin or cephalosporins. Evaluate lab results, looking at hepatic enzymes, tissue injuries, nausea, vomiting, and we also want to keep an eye on the patient's white blood cells, as this will be a major indicator of how effective we are at removing that infection. We always want to obtain a sample for lab culture and any antibiotic sensitivity testing to determine the infective organism. We want to monitor for any evidence of superinfection, especially in patients taking high doses of antibiotic, and examine the patient for any allergic reaction. Cephalosporins, these inhibit bacterial cell wall synthesis, are considered bactericidal, and used to treat things like pharyngitis, tonsillitis, otitis media, and can be grouped in first, second, third, fourth, or fifth generation. In the case of first generation, these are effective against mostly gram positive and some gram negative bacteria. In the case of second generation, they're effective against gram positive and gram negative bacteria, though only some are affected by beta lactamases. In the case of third generation cephalosporins, these are broad spectrum antibactericidal activity, effective against pathogens like Pseudomonas and resistant to beta lactamases. For fourth generations, these are again broad spectrum, highly resistant to the destructive beta lactamases, and provide good penetration to the cerebrospinal fluid. And finally, for fifth generation, these are again broad spectrum and also highly resistant to destruction by the beta lactamases. The side effects of cephalosporin would be again anaphylaxis, superinfections, headache, dizziness, GI distress, increased bleeding, elevated hepatic enzymes, nephrotoxicity, and that Clostridium difficile, which is going to be a major danger with any antibiotics we're giving the patient. Cephalosporins can also have many interactions, everything from alcohol, causing a disulfiram like reaction, including flushing, dizziness, headache, and nausea, vomiting, to anticoagulants, where they may increase bleeding, or loop diuretics that can increase nephrotoxicity. Much like with penicillins, we want to assess for any allergy to cephalosporins or penicillins. Look at the lab results, evaluate those renal and liver functions carefully, looking for tissue injury, nausea, vomiting, and keeping a close eye on the white blood cells. You want to culture the infected area before cephalosporin therapy is started. Tell the patient to report signs of superinfection. Instruct the patient to take the complete course of treatment. With any antibiotic, they need to take that complete course to make sure we've completely eliminated that pathogen. For our first practice question, which nursing intervention has the highest priority for the patient who's taking cefepime? A. Wait until culture results are received before initiating antibiotic. B. Monitor the patient for signs and symptoms of a superinfection. C. Administer IV over 2 hours to prevent phlebitis. Or D. Instruct the patient to take the drugs for 5 days only. And that answer will be B. Monitor the patient for signs and symptoms of superinfection. A patient is taking piperacillin tazobactam, Zosyn. Which nursing intervention are most appropriate for this drug? That be A. Give with an aminoglycoside. B. Send specimen to lab for culture and sensitivity before antibiotic therapy is started. C. Instruct the patient to take the entire prescribed drug. D. Instruct the patient to restrict fluid intake. Or E. Monitor for symptoms of superinfections. That answer is going to be B, C, and E. B. Send the specimen to lab for culture and sensitivity before antibiotic therapy is started. C. Instruct the patient to take the entire prescribed drug. Or E. Monitor for symptoms of superinfection, including stomatitis, vaginitis. A patient enters the emergency department with a draining wound. What is the priority nursing intervention once the patient is admitted and assessed? That be A. Administer the ordered antibiotics. B. Teach the patient about the ordered antibiotics. C. Culture the wound. Or D. Enforce droplet isolation precautions. And that answer is going to be C. Culture the wound. And for our final question, which statement will the nurse include when teaching a patient about cephalosporin therapy? That be A. Avoid ingesting buttermilk or yogurt when taking this medication. B. Stop taking the medication when you feel better. C. Immediately stop taking the medication if you develop nausea. Or D. Inform the healthcare provider if you develop mouth ulcers. And that answer is going to be D. Inform the healthcare provider if you develop mouth ulcers. Antibiotics were and are a miracle drug. People, since Alexander Fleming's invention, are surviving infections that would have been fatal for the entire previous human history. At the same time, there is a flaw. We are going to eventually run into the day where we meet a bacteria who is completely resistant to all antibiotics. It's not a matter of when, it's a matter of if. And unfortunately, we are in that arms race. And one day, tuberculosis is a very scary one in that regard. But at the same time, they're also going to be a facet of about any. I can't think of a single nursing specialty where antibiotics would not be used and given in some form. They do a lot of great things. For us as the nurse, we want to make sure that we're carefully monitoring this patient. Some patients are very allergic to these. Keep the eye for any C. diff. C. diff is going to be a danger across the country. And a lot of those cases are from a result of the antibiotics we're given. But anyway, just some food for thought for wrapping up. That's all I got for this chapter. I'll leave you in the next slide. I'll see you in the next slide.